Hello everyone. Today we are going to discuss a very important topic, which is gout in CKD, a very commonly encountered scenario in the OPD. So as to the management of gout in CKD, you can divide it in acute, flare and the chronic management or the prophylaxis. So in the flare, in the acute flare setting, avoid NSAID because in such patients there is a high risk of causing AKI over CKD. If at all you are using NSAID, use it as a short course, a relatively shorter acting NSAID. But the safest drug in all stages of CKD is prednisolone, that is steroid, 20 to 30 mg per day for 5 to 7 days, and then you slowly taper it off. You can also use intra-articular triamcinolone if the presentation is monoarticular, because that is the usual case. The other option you can use in acute setting is colchicine, which is 1.2 mg stat, and you can repeat it after 1 hour provided the eGFR is above 30. If it is less than 30, you just give a single dose 0.6 mg stat and do not repeat this colchicine within 2 weeks. So that is it. So the preferred agent is prednisolone, and if not available or if not tolerated, you can use colchicine. For the flare prophylaxis, you have to use urate lowering therapy. The best option is allopurinol. You start it off as a 50 mg once a day and then slowly titrate it off to 300 mg maximum per day. And if there is appearance of rash while you are using this drug, immediately stop it because it has a risk of causing Stevens-Johnson syndrome. The other option in urate lowering therapy is febuxostat. It is not a good choice, so avoid in severe CKD, that is less than 30 eGFR, you should avoid it. And also if there is a severe cardiac disease, you should avoid it. If it is a mild to moderate CKD, eGFR above 30, you can use it as a 40 mg once a daily dosing and slowly titrate it to 80 mg once a day dosing. The preferred agent, however, is allopurinol. And mind you, while you are using the urate lowering therapy, after the acute attack has subsided, you have to use a flare prophylaxis colchicine, because once you have started using allopurinol or febuxostat, there is a rapid shift in the uric acid milieu and that can trigger a flare. So you have to use colchicine in such patients for 3 to 6 months. But mind you, since it is a CKD patient, so you have to use 0.6 mg once daily. If the eGFR is above 60, you can try it twice daily, but better to stick to once daily or even alternate day dosing. If the eGFR is much low, continue it up to 3 to 6 months. So in overall, avoid NSAID, use prednisolone oral or intraarticular in acute attack, and in the flare prophylaxis, use allopurinol, that is the safest thing. And if the patient is on a uric acid lowering therapy before, that is if he is a patient who is taking urate lowering therapy from before, do not stop it in the acute attack. Versus if there is a patient who is a treatment naive and it is the first episode of his acute attack, then you cannot start urate lowering therapy on the presentation itself. These are two different things. If the patient is on urate lowering therapy, do not stop it. If the patient is not, that is the patient is a treatment naive patient, do not use the urate lowering therapy on the first visit. Give it after the attack has subsided, acute attack subsided, usually after 2 to 3 weeks. That was it from my side. Thank you all.